Now I would request Dr. Bashir Hanif for his talk on the crop registry.
Thank you, Nader. Sorry, this is not in the program, but it was supposed to be yesterday. We couldn't do it. First of all, I would like to thank all my colleagues who are there virtually. Rajiv, you have been a great friend. I remember the day I joined as an international fellow, and you were the international consultant who had just come in. That was your probably first day, and we did the first case together, and it was great. Thank you so much. Thank you, Paul. Thank you, Fahim and Hafsar, all being there, Dr. Payo. I'm very grateful for sparing time to be here, as well as Javed. So I think what I'm going to do is very quickly over next 5 or 6 minutes for my friends online. I want to tell you that in Pakistan, I've been trying to work hard to get a kind of a registry data or like NCDR. So as soon as I moved back, I started working on it, and it took me like almost 20 years, but now we have been able to have our own registry, CAT PCI registry in Pakistan. So I would say that we have taken the first step in a 1,000-mile journey, and we were lucky that Supreme Court helped us and make it mandatory for every cath lab to put in the data online in this registry. And I've been working on it for a long time, and now we have collaborated or working together with Pakistan Society of Interventional Cardiology. So I am presenting this fourth annual report of Cardiac Registry of Pakistan, CAT PCI, on behalf of Steering Committee of CROP and on behalf of Pakistan Society of Interventional Cardiology. The purpose of presenting this report is I'm going to quickly go through it, although we have a printed report available, whoever want to look at it in detail. But the main purpose is to really to acknowledge those who have been entering the data, and to kind of basically try to motivate those who have not been able to do it fully to be able to do it. It's a great resource. I think yesterday there was a talk in our Sky quality session. How can you use the registry data in the cath lab to improve the quality? And it was amazing. I would request everyone that please, if you have time later on, go and see that recorded talk. How it can be so helpful to improve your not only your own quality, but also the care you provide to the patients. So I think the ultimate purpose of collecting the data is to provide a basis for action or a recommendation. And I would just tell you that over last year or so, we have the data of almost like 152 cath labs that almost, not 100%, but I would say more than 95% of the cath labs are entering the data, and they had been registered. Out of those 152 cath labs all over Pakistan, we have 133 labs that are registered with the CROP and entering the data, and they spread all over Pakistan from north to south. I think all the major cath labs except 2 major ones which are still not there yet. One is NICVD, another one is Punjab Institute of Cardiology. They are just starting to enter the data, but rest of the labs are registered and they are putting in their data, and I'm really grateful to all the labs and their directors who are doing that. So from January to December 2022, we have almost 86,000 procedures that were entered in the CROP, and out of those 53,000 were diagnostic CATs and around 32,000 PCIs. Remember that this is not all the data, because there are labs who are already registered, but they are not putting all the data, and I'll quickly show you number of PCI. Now submitted, those that has submitted, this is like from 0 to 100. These are the labs which are submitting the data over a year. Less than 100 patients, they entered the data in the registry. Then 100 to like 600, these are again just rough numbers. And we have like Gulab Devi, Hamid Latif Hospital, which are on the top, and similarly Afridi Medical Complex. And then we have centers that has entered like almost around 600 to 1,000 patients in the registry, and these are like include Baria, Bawalpur Victoria Hospital, Shifa International, Farooq Hospital, Doctors Hospital, and obviously I don't have time to go over all of them. But I think more than 1,000 patients is the one which really I want to acknowledge and appreciate and thank all of them. Rawalpindi Institute of Cardiology, Multan Institute of Cardiology, Peshawar Institute of Cardiology, Fauji Foundation, Tabahat, PIMS Islamabad and Wazirabad Institute of Cardiology. They have been very particular in putting all the data, and I'm thankful for that. And again, with data collection, the sooner the better is always the best answer. If you look at quickly admit source, almost 70% were elective, only like 20% were emergency department. Again, I think the most of the data was from Punjab because one of the major center, NICVD from Sindh, was not entering the data, but it's mostly, if you look at it, it's the Sehat Sahulat card was the major patient base or volumes which were there. 70% were males, around 30% females. Again, age distribution, if you look at it, it's relatively younger, 41 to 55, almost 40%, and 56 to 69, almost around 30%. Comorbidities, again, I think I won't be going into the details, but these are the kind of things you can pick it up. Hypertension was one of the most commonest one, followed by diabetes in these patients. And I think the future of the medicine is increasingly in hands of those who are effective users of clinical data. This was said by one of the well-known cardiologists who was actually running the NCDR at one time. Presentation was mostly, again, 53% were non-ST elevation ACS, around 20% were ST elevation MI, and non-ACS were around 30%. Arterial axis mostly radial. Diagnostic cath, coronary anatomy was equally divided among single, double, or triple vessel disease. Again, if you look at the treatment options, most of the patients went to PCI, which was around 44%, followed by medical therapy, and cabbage number was surprisingly relatively lower. Again, I think the credibility of data, we have to work on it, and accuracy of data also, we are going to work on that as well. Elective, as I said, almost 80%. PCI indication, again, high risk non-STEMI or unstable angina was the most common indication. No, this was a little bit problem. Average door to balloon time was 91, but this was like huge spread, plus minus 160 minutes. And that was one of the major issues. Again, I think there are issues in the data. Number of treated vessels, again, one vessel disease obviously was the most commonly found and treated. Chronic total occlusions. Again, these numbers were not that much. Similarly, bifurcation numbers were there. Overall, they are not huge because of the cost issues. I think they don't end up going for angioplasty. Again, stents were used in almost 90%. POBAR, deferred PCI around 9%. In hospital events in these patients, again, unfortunately, these numbers I would be, again, there's a significant problem because a lot of people are kind of shy away from putting in the actual mortality or actual outcomes. So again, I would take these numbers with a pinch of salt, and we are working on this, how to improve that. Bleeding events, again, were very small. Again, those numbers may be a little bit difficult. We have inbuilt appropriate use criteria, and according to that, around 35% were appropriate, uncertain around 30%, inappropriate around 3%. Discharge status, again, mortality is very low, and again, I would say this we have to take with the kind of a pinch of a salt. So discharge status with overall presentation, STEMI patients, non-STEMI and non-ACS, again, their mortalities were very low, which are kind of a little bit unusual. So I think the purpose of showing this data is, again, to really kind of apprise all of you that we have all this data. Currently, we have almost 130,000 plus database with almost 400 variables, and a lot of fellows and other people who want to actually are interested in research, they can do that. And that is the reason why I said this is the first step in a 1,000-mile journey, because at least we have started it. There are a lot of issues, missing data, inaccurate data, but I think it's going to take time, but hopefully, inshallah, we will be able to achieve those things in the near future. We are collaborating with NCDR. Dr. Payo is there. Myself and Dr. Payo are on steering committee of NCDR, ACC NCDR, and we are trying to get help from them how to improve the data collection and overall quality of the data, and how we can really involve everyone to do some research and come up with papers and everything. So with that, I would say thank you very much. I think we'll have to move on to Punjab Institute of Cardiology to do the live case. Until unless if somebody has any quick comments or questions regarding the crop or maybe earlier talks, we can give few minutes and then go to PIC.
Bashir, I have one question about these crops. I think you have done a lot of work on this registry, and I think it is very creditable. Are we not underestimating a little? Are you going to improve the number of entries in the register?
I'm sorry, can you say it again? I didn't understand.
I'm saying, I mean, it's a great, you see your great effort. Can you hear me now?
Yeah, I can hear you now. Sorry, the PIC lab was talking, so I couldn't understand. Can you say it again? Sorry.
I think you have done a tremendously, wonderful job to, get this registry on. Are we not underestimating the cases? Are we doing something to increase the entries?
To increase what, sorry?
I mean, entry into the register.
Because yeah, definitely. We are working on that. I personally sit every week and call almost like in a month, almost every cath lab and keep telling them to enter the data correctly and complete data, and gradually, like I think every month, the entries are improving. And again, I think the accuracy of data, we need to work on that as well.
I think it's a great start. Hopefully this will grow up, inshallah.
Thank you. Thank you so much.
Assalamu alaikum, Salman and Cath Lab, how are you? Can you hear us?
Good, thank you very much. How are you doing?
Great. So what's happening? What's the case all about?
So I'm going to have my colleagues present the case, and then we'll go from there.
Okay, Dr. Imran. Okay, I will present. I have a mic. So, Dr. Suhail, I am Dr. Muzaffar, with me, Dr. Salman, Dr. Rashid, and Dr. Imran. So, he is a 57-year-old gentleman. He has history of anterior valve. Recently was thrombolized, and we did angiography which show critical mid-LAD stenosis. It was the culprit vessel, but at the same time, he also have a history of stenting in RCA and presented with grade 4 ISR CTO. So now our plan is to go for CTO PCI. If it opens, then it's okay. Otherwise, we will go for cabbage. So over to you, Dr. Salman.
Can you take us through the angiogram, please?
So angiogram.
So this is a young man. Obviously, he's got multivessel disease. This is after thrombolysis, and I think the decision was to attempt the CTO first, and then fix the LAD if we succeed. Otherwise, consider bypass. And I think one question right off the bat is, what would some of the people on the panel have done? I think in my setup, where we practice, typically, we do a lot of primary PCI. Even after lytics, we tend to go and see the patient. And many of us might have considered sending him for bypass. I might have done the LAD, but what does the panel think? I just want to get some opinions.
So there looks like a stent in there already. Is that it's a stent closure or ISR?
It's ISR. Okay. So you can see that the stent, do we know the duration? How long ago?
It's 7 years back. In 2016, first PCI was done to RCA.
So the stent was 7 years ago. And, one of the questions always is with the mechanism of stent failure. Was there something proximal disease that was missed, geographic miss? Is the stent undersized? And obviously, if we do end up crossing this, we'll have to do IVUS to understand that.
This is a very, this is a young patient, and looks like there is some antegrade flow, and I would try to attempt to do percutaneously in this situation, and hopefully you'll be able to cross with one of the stiffer wires.
Excellent. I think I agree with that. So,
Fahim Jaffrey here of Singapore. I'm slightly dissenting view. I would, this guy came in with this acute MI and then post-thrombolytic. We would have just fixed the LAD, IVUS guided, of course, and then reevaluated whether we need to do anything about that right. It looks chronic. It must have been there potentially could have been there for years. And I'm not even sure whether he would benefit from a procedure unless he has symptoms. So we would keep all those considerations and evaluate all those considerations. But off the bat, I would just fix the LAD first.
I think there's a lot which can be debated for this. I wonder what the interfair wall is like, because this ISR has been there for quite some time. It's not the acute event. So like Fahim said, that, you know, if it's acute syndrome and you want to get sort that out, then come to the RCA later. But, you know, I mean, there's great logic in trying to open this vessel. If you couldn't fix this well, then we can say, okay, let's talk about surgery. Because it's an ISR, so even if do a PCI, the chance of recurrence in a PCI post ISR, the incidence of ISR is much higher than the first time. So, any other comments from the panelists?
That's a good question.
Nadeem Saab, how would you answer Nadeem?
Let me find out. How long ago did you get the thrombolytics?
This is definitely a very difficult artery to handle. So guide support is very important. I think there should be an appropriately supporting guide to handle this sort of anatomy.
The lesion in the LAD is relatively non-complex. So after fixing the LAD, I would just go straight to fix the right coronary artery. And I think one stent in the LAD would do the job. And then obviously this ISR lesion would be treated even as after completing the LAD procedure. So I think, as I said earlier, there's an antegrade flow and the chances of getting the wire through are relatively good.
Purely for being a devil's advocate and saying that if we do a PCI to the LAD and it's acute syndrome, it is a no flow, slow flow, then we'll have a real disaster on our hand because, you know, the RC is totally gone, circ's not that big. So I think we all have different ways of going about it. Let's see what your plan was, Salman.
Okay. So, no, I'm at the mercy of the people who set this up. I agree with Fahim. So had this been my practice in the US, we would have stented that LAD because if you think about the natural history of this disease, this ISR has been there potentially as long as 7 years ago, right? We don't know when it shut down. And he wasn't having any symptoms. He's presumably got a near normal ejection fraction. And all of this was triggered by his STEMI. So if we go and take care of the LAD, he may or may not even need that RCA fixed. So I think so what we would have done is probably fix the LAD, given him medical therapy, and maybe in 4 to 6 weeks, we would have done a PET scan to see his ischemic burden. But at the same time, I'm also here to teach. So whatever I think the panel agrees upon, I think we'll do this. And you let me know. We'll fix the LED and then we can attempt the RCA today within this hour, or we can do the RCA first.
Can we have show of hands? How many would do the RCA first? And let's show of hands for LED. Okay, there are about 20. Let's show the hands for RCA.
LED.
Yeah, okay.
LED first,
so 80% want us to fix the LED.
Later on, RCA.
Salman, 80% here want us to fix the LED.
Okay, so
They're all
let's
suicidal, I think.
Let's fix the LED. If you guys have a talk, while we set this up, LED PCI. What we'll do is we'll set up the guide. We'll go ahead and wire it, angioplasty, and IVUS the LED to make sure that we have appropriate stent sizing. And then hopefully we can work on the RCA before time runs out.
So you're going to take the wires out from you got double guiders?
No, we don't have a double. We have a diagnostic and a guide. So let me just get the guide for the LED.
Salman, we weren't planning on a democracy here. We just wanted to see how you do it.
You know, that's true, but I think we also want to keep the patient. Well, let me see where we are with the guide. I hope I haven't pulled it out. I think I pulled the guide out. How much time do you have right now?
15 minutes.
15 minutes? Okay, let's see what we can do in 15 minutes. If it doesn't work, we'll fix the LED. And again, the idea is first do no harm. So let's have the Mamba again.
Salman, with your skill set, Salman, you probably can do the LED in 5.
But I need the guide open. The problem is I don't have a guide. I'm at the mercy of the guide right now. But what I'll do is, so one of the things that I talk about a lot is contrast modification of plaque. I think that's something that a lot of the folks have wanted to see. And this is a good place to try it, right? Because the stent acts as an exoskeleton, so we're less likely to cause trauma there. So let's see if we can do the RC in the 15 minutes that we have. And if not, then I'll do the LAD. Either way, he'll leave with more blood flow than he has right now.
So which wire are you taking now?
There's a lot of logic in that, Salman, because the circ is not, there's no big AV circ or, so the RC is dominant and there should be a very big vessel there. So there's a lot of logic in...
I agree that it is underfilled. Now, one of the things is that, in choice of microcatheters, the only sort of randomized study with the crossboss, a lot of my colleagues in the US use a crossboss. I typically just use a microcatheter, see if I can make my way across, and then I'll show you how I use the contrast to make a channel across, or at least cause some hydraulic dissection to open up the channel. But I don't know, what does the panel think about the best microcatheters?
Will it be a modification of a Carlino, Salman?
I will go with the Caraval.
Okay.
For a diffuse ISR, cross-boss is a very good, effective way of dealing with it.
I will start with the stiffer wire right at the beginning with the Gaia 2.
So which wire are you taking, Dr. Salman?
So what I was going to do...
For the crowd, what kind of wire would you use to cross
and
this
why not
diffuse
something like an
ISR?
XTA or...
I think probably because of the restriction of the number of wires I gather in Pakistan you can use. If you want to have a higher success, I will go with the wire which may have to use only one wire. That is one of the reasons, I agree with you. I think XTA could be tried here, but just to sort of reduce the cost rather than using about 3 to 4 wires.
Yeah, I get it. That's a very good, very valid point.
If you say that it's a single wire technique, would you go with the process?
We've got some very eminent guys online, Itisham, Dr. Payo, Fahim. How would you go about dealing with this? And what about, now that we started the PCI, what about the choice of equipment?
I think one thing I've noticed that I would have gone with the AL 0.75 or AL1 catheter, guide catheter, because you may have trouble maybe later on actually, rather than the JR4 catheter. That's at least AL 0.75, AL1, 7 French.
Is that a 7 French, Salman?
No, that's a 6 French, and I agree with that. Show that, please, Flora. So those are all great points, and again, I'll tell you that the diagnostic procedure had already been done when I joined. So again, AL1 would have been a good choice, but they have a JR, and the JR is fairly deep. So before it gets too soft, I'll try and use that. Can I have the Gaia, please?
Yes, Gaia too. Okay.
That's a great,
So
I mean, you need a good guide support. That's a very important thing in this.
We've taken a workhorse, we've got taken a Gaia 2 or Gaia 3 could be.
I think you want to, in my opinion, you want to keep the procedures as simple as possible, having a very good guide catheter support, using a stiffer wire right up front and with a microcatheter, and your chances of success are going to be higher than if you start with the JR4 and with other wires.
What kind of stiff wire do you have in mind?
Salman, is that wire in the RV branch or the RCA? Because you're kind of you're in the RV branch.
Okay. So this is one of the ways that I try to keep the contrast or air from entering a wire. So I'm flushing the hub because if I do a Carlino here, I don't want any contact. But you can take the wire out. Okay. Carly? Pull. Yep. So what I'm doing is I'm flushing the hub to make sure that air doesn't get in. Okay, so I've got the guy now. The way I do Carlino, and kind of this is in conjunction with Morrow, is we cross the CTO and then we try to do a gentle injection at the tip. So what I want to try and do is I'm going to use this Gaia to redirect within the stent architecture and see if I can get beyond the cap. So I used the RV branch to my advantage. Wire was there, I got the microcatheter down, now I'm trying to redirect the microcatheter down into the occluded portion.
Salman, this is Javed from UK. Can I just ask you, if you manage to cross this lesion with a Gaia second, would you be doing imaging up front?
Yes, absolutely. So the goal is to get it and then see if we can somehow get an IVUS down there. Now we have the volcano system, so I may have to do some angioplasty before we do that, but absolutely. Okay, now this is going very smooth. Did you see that? Okay, so show that please. So one of the things about ISR is that the neointima grows in layers, and usually there's a potential microchannel there, and the Gaia does a really good job of capturing it. Now the catheter that I was given is a Mamba Flex. Now the Mamba is a Boston Scientific catheter. It is somewhat sort of tipped to hub sort of stainless steel. It's torqueable, but sometimes it's a little stiff. So let's see if this goes. Now one thing, I don't know if you can focus on my hands, is how do you hold one of these to torque it? This is something I like to teach. So it's a bit like riding a bicycle. You hold the hand closest to the hub, you hold the microcatheter there. The other hand, just before you hold onto the hub, you give it a rotation away from you just a bit, and that's how and now you have it. So now I can spin it this way, or I can spin it back this way. So I'm gonna see if I can spin this forward. Oh, the wire came back. Let me see if I can get the wire down there.
How far do you like to take the wire down?
So just shy of the distal stent edge.
That shyness is because of the Gaia, or that is because of...
Of the Gaia, because what ends up happening is that the stent, and again I'll defer to the panel here, but typically the vessel is underfilled and is spasmed around it. So if you go out with the Gaia, you can potentially get subintimal. So now that I've crossed the C2, I'm in the C2 itself, Flo, can show up. You can see how I use the microcatheter. I spun it forward. I use my pinky to hold onto the torquer. And now my catheter tip is very close to the exit port. So now I'm going to do my Carlino injection.
Yes, this is 1 cc.
Maybe this is contrast. I need saline first. Okay. What we're first going to do is we have to make sure that we don't get air into the system. So I'm going to again flush the hub. Ye taar nikal le. Pinch le piche. Yep. Good. And you can see I'm tipping the catheter upwards, and this keeps any air from entering.
So Salman, do you try wiring the vessel first and then use this as a fallback, or you just go straight with the Carlino?
No, I do the Carlino, and it's one of the sessions I had on the site today. Because if you go with the wire first, the wire will go ahead and make a channel, and then the contrast goes along that wire. So well, the latest iteration of Carlino is you cross the cap, and you do a gentle injection about 0.5 cc's, and you see the shadow as the contrast streams out. And typically, it will make a channel through the plaque into the true lumen. Acha. So what we've done is, I've got a sort of airless system. I'm going to pull back. And this pulling back does two things. First of all, it eliminates, make sure there's no air in the system. But the other thing, it lets me know if I've crossed or not. Because if I pull back and I see blood coming back, which I don't, then I know I'm across. But clearly, I don't see any blood. So now I'm going to go ahead.
A thing to note is, Salman, that it has to be a 3 cc syringe with the lure lock.
There we go.
So you are giving it at a gentle pressure, right?
Yes. Okay. So I'm going to do Carlino injection here now. Oh, आपकी syringe. कोई तगड़ी syringe है कि नहीं?
10 cc वाली दे दें, 10 cc.
या lure lock वाली दे दें कोई?
Lure lock नहीं.
Achha, so we use the lure lock syringe for this because, you know, it's a very small microcatheter. So the syringe broke. Oh, no, hand's fine. I just need contrast.
And this is 1:1 contrast or diluted?
This is 1:1. So the way he's doing it right now is he's using 1:1. Let me try I can do this without breaking the syringe. And the idea is that you watch it sort of make this channel path of least resistance through the plaque. There we go. Perfect. So here, interesting thing. So we saw it. We're in the CTO. That's why the contrast is refluxed a bit. You can see how we're much deeper than the original occlusion. And also where the contrast has hydraulically made a channel, you can see now there that there's It's a little wider channel. Okay. Now we take a hydrophilic wire to go across. Filter XT here?
Filter XT then.
So what Carlino recommends is a Mongo wire. We don't have Mongo here. So we'll actually try a Feeler XT.
I think with this technique, you can use any hydrophilic wire, honest.
Yes, true. Any hydrophilic wire. I like the Feeler XT because of its tapered tip.
I think once you have actually created the channel through the neoatherosclerotic vessels, I think any hydrophilic wire hopefully should cross.
Agreed. And so we've used Feeler FC, we've used, we don't use pilots anymore, Feeler FC, Mongo, or Feeler XT.
I think Feeler FC would be a good choice.
I don't know if I have. So I'm going to try this without the tip just to see how the tip follows the contrast and if you've truly made a channel or not. The question was, why not pilots? I think in our system, we just, we have to choose number of wires.
Salman, have you cleared the micro with the contrast with the saline? Or, because if you do not clean the micro with the saline, the contrast in there sticks to the wire, makes manipulation easy.
I'm just doing that. This lets me know that the wire is coming. I haven't cleared it at all. That little staining you see at the tip, that's adventitial swelling. So you don't want to, you should be fine. Again, acha. So now we're close to the tip. Now I'm just going to slowly advance it and see if it just takes a true channel, and hopefully it will. Okay. See some resistance there, but I think we're moving the true channel. So store that, and let's see if you can do retrograde injection at this point.
Yes. Is it engaged? Engaged.
I think here your AL catheter would have been of great help.
Yes, for support. Agreed, 100%. Rijega, isme koi car hai wire?
3 wire.
Yeah, so they have a diagnostic. That's the other thing, when we do CTO, we try to get 2 guides in.
So collateral were not good actually.
AL catheter versus an XPR catheter, which is now a current trend.
I like AL1, that's what I trained on, and
yeah, AL1 is one of the best catheter for sport when you are doing CTOs.
you can see we have the balloon prop on standby. That's always something we talk about being, okay. Let's just take a picture here.
Yes.
You contrast your pehle wala? Okay. Yes. So we're in the true lumen. You can see that.
Yes.
Yeah.
Okay. So now, let's see. Now again, this is where again an AL1 would have been great. Guide extenders would have been great. But let's see how the Mamba behaves. I'm going to see if I can get this Mamba to go forward. Now the thing about Mamba is the surface dries up quickly. You have to keep it wet.
The distal vessel looks much better with this injection than the first ones. I wonder if it was a harder injection or something else.
Salman, now you know that you are in the true lumen. Why not to take the caravel all the way down and put it to slightly more sporty wire?
Yeah, no, I agree. That's what I'm trying to do. So we didn't have a caravel. We have a Mamba. I'm going to see if I can use that. Nita, I might have to change out for a different, you can see just pushing the wire causes the guide to come out.
I think either you need to have a very sportive guide catheter, which is not there, but now a sportive guide wire would help, particularly when you...
And we know we have a channel, so maybe you can just take a supportive guide wire without any tip on it. अच्छा आपका सॉल्व वायर कौन सी है? What's the supportive guide wire that you have?
BH.
BH?
Yes. Would like to have 350 long wire now?
350 दे दें.
350, yeah. 300.
So Salman, do you use this for all CTOs or this specific just for ISR?
So no, so Carlino, I've been doing it for all CTOs for about 6 months, and we found that actually is successful quite a lot of the time, and it basically sets you up for ADR if you need to. But more often than not, you end up going through intraplaque. So this is intraplaque dissection. And the nice thing is, if you can't go antegrade, you can come retrograde. Now, one thing I want you to notice that there is no contrast staining. So the one concern that comes up is, will you perforate the vessel? The injection is so gentle and it's intraplaque that you just cannot, unless you be very aggressive. That's power Carlino, right? So that's when you try to purposely go into the extra plaque space. But this is just a gentle injection. Did you have another
Salman,
wire?
Salman,
So
I
what we'll do,
know
let's try
it's.
to get another wire there. It's not a very big vessel.
Salman,
I'm limited by inventory here. If this doesn't work, then I might trap this out and get like a 1.5 balloon, make my way down to the stent and go from there.
Salman, if you are sure,
Okay,
like in just one view,
Wait,
how
one
can you
thing
be
you-
sure that you are in the true lumen? Because if you are in the true lumen, you should have been able to get the wire further down. So I will be very reluctant just to base on one view saying that it's in the true lumen instead of a dissection plane or something.
That's a good question. Let's try a different view. We could be an RV branch. That's a great point. So Aryo Demute, let's just say Aryo view, please.
A contralateral injection would answer that.
It could be still in the
Is
dissection
that
plane.
Salman, is that the new wire?
No, we don't have the new wire yet.
All right.
Okay.
Saline.
Bashir, it's in there. The problem is that there's a spasm, and there is some degree of, some plaque there. And you can see the challenge here of not having a guide with more support. So, you have the BHW?
Yes, BHW. No,
Do you have an exchange whisper? Let's try an exchange whisper.
Exchange for 300.
If this doesn't work, then we'll just trap this out. Yes.
Extra support.
Extra support. If this doesn't work, we'll take this out and we'll use a smaller balloon to angioplasty halfway down the stent, maybe get the guide deeper and then go from there. I think it's a support issue. And unfortunately, I don't have a proximal RV branch to anchor against right now.
Can we anchor the balloon on RV branch to have a good support?
It's chip and guide, no? So one of the challenges, obviously, planning is a big part of this.
So Mamba does not go for.
Bamba is not going forward. Let's go to the LAO view again, please. And this is Saline.
Dr. Salman, can you use a guide catheter extension for increasing your support?
Absolutely, but problem is we don't have it in right now, so I'll have to take this microcatheter out before we take it. Okay. But one thing is nice, it is wedged in. So just to your point, I do use this technique for all my CTOs. If this was not an ISR, then at this point, I would have put a rota wire across and done that.
What is the role of
We've all talked a lot about Carlino technique and how to inject into a plaque ostium, Salman, but a purist CT operator would never inject into the micro unless he's absolutely sure. And they rather aspirate and see if blood's coming or not. So it's very contrary.
Yeah.
We admire this technique and we all want to do it, but there's a little downside to it that, you can create a hematoma there. How about an epicranial view? That would probably spread the vessels out a bit.
That's a good point. That's why the contrast injection has to be gentle. And you watch exactly where the contrast is, so it doesn't go out into the extra plaque space. But power Carlinos, that's what they do, they try to get extra plaque. So what they recommend is not injecting antegrade if you've already done some work up top, because then you can form a hematoma. Because the catheter is so deep into the plaque, it won't form a hematoma because it has to go outside before it forms a hematoma. So if you start doing proximal injections, I think that's a little bit more risky. Now you see that the field actually has gone a little farther now, the whisper wire. Let's just go eleocranial and take a picture in that view. 25 eleocranial there. Can we do? There you go. Yeah. So now the problem is not crossing the CTO. The problem is actually trying to get some support. So what we're going to do is we're going to take this Mamba out, and I'm going to go with the 1.5 or 1.0 balloon and see if we can build up some support up top. And maybe I'll deep seat the GR4 and go from there. Walk it back.
How are you going to take the micro out? Will you blow it off, or you going to anchor it?
The guide is moving too fast.
Yes.
And you got no guide catheter extension available.
No,
I think
but that's the other thing. I think we don't have a whole lot, but if they have one here, I might use it next. After
We have.
Yeah, I think with the GR4, the next best thing is to add a guide catheter extension.
I think that's what we're going to do. We're going to add the guide extension, and then we're going to build our way and trying to get the guide extended halfway down the stent. So इस तरह करें, मुझे guide extender दे दे and give me a 1.5 balloon, and then have a 2.5 balloon ready after that. 2.5/12.
Actually, I think in this situation, Salman, you can do a bat of guide liner, which I use it most of the time. Rather than going over the balloon, you just inflate the balloon halfway into the guide catheter extension and do a bat like you do through the brachial artery. So that is the bat of guide catheter extension.
Yeah.
Can you say that
right.
again, Dr.
But the
Sham?
1.5 balloon is for the distal lesion, for where the Mamba is getting stuck.
Right.
Yeah. So what I'm going to use, I'm going to do two things with that balloon. I'll dilate that lesion where the Mamba is getting stuck, and we'll anchor that and get the guide extender in. मुझे गाइडजिला देना है आप जो है
पहले गाइडजिला
नहीं पहले गाइडजिला
गाइडजिला
पहले गाइडजिला and then so we'll do a telescoping thing. We'll get the guidezilla, and then we'll put the 1.5 balloon. We'll dilate the lesion, and then we'll put the guide extender at the same time.
Okay.
And you're right. I think BAT works great for this. We also call torpedo technique.
So how far into the plaque do you wedge your microcatheter, Salman, before you inject?
Fahim, about 2 millimeters, no more. And what I'll do is, because I know you had the responsibility of being on the panel, inshallah, I'll send you a copy of my slide set from today, just because that describes the technique in there.
Sure, I'd love to see them. Yeah. Thanks.
Yeah, and right now we're trying to compile our, we've done about 60 cases. We're going to compile them for TCT, hopefully. We're trying to get the registry going with Carlino. So I use it also for my tibials. I do a lot of fingers and hands. I use it for that too.
Okay.
And so far it's been remarkably well at modifying plaque.
I think it works slightly better with ISR type 4 lesions rather than the de novo.
Absolutely. And I think the reason for that is because there's a potential channel in ISR.
That's
and with
right.
de novo lesions, sometimes there's so much calcium. There's so much calcium that it deflects the contrast into the subintimal space. Though, even in those cases, we've been able to get it sort of to go around the calcium. Asha, can I have I've got this 1.5 balloon there.
1.5. ACT कर लें check. Okay. हाँ ACT check.
और मैं 1.5 balloon भी दे दें please.
तो ये बाकी चीजें पीछे रखते हैं.
ये गाइड कौन सी है तो उसमें जान ही
Fixed branch.
अच्छा चलें let's just see. I'm having some issues with resistance of the guide extender, the guidezilla tip. Sometimes, these guides get kinked. अच्छा दोबारा zoom बढ़ा दीजिएगा to 6 inches if you can. Okay, yeah, पकड़ लें वहाँ.
Do we plan to do an ACT at some point, Salman?
Hanji?
Yes. Do we plan to do an ACT at some point?
Sorry?
Do we plan to do an ACT at some point?
They're doing it right now. The sister's doing it right now. I'm just keeping off Flora because I don't want to radiate her. So inshallah, as soon as we... Now, we have the other, we can do ACT from here also.
Yes.
Why don't you give me ACT syringe यहाँ पे दे दे?
Really?
हो गया? अच्छा ठीक है. So, this is very efficient on-the-fly phlebotomy. It's amazing.
So what's the plan now, Salman? What is your strategy?
So now we need to build up support. So now we're dealing with a different problem. It's not an uncrossable, it's wire cross, balloon crossable lesion. We have to build support, and that's why many microcatheters fail. The guide is probably softened by now. So the way we're going to build support is we're going to angioplasty the neointima, make enough room for the guide extender to come down, and then reattempt with the balloon to see if we can go across. And then we'll do nitro and then IVUS.
Would you consider using a 1.0 or 1.25 balloon and trying to see if it goes
That's
through?
What we have.
Yes, we have.
We have 1.5, but yes.
I wonder if 1.5 is a good choice, especially when you can have it as small as possible and seeing how that goes.
I think the balloon is crossed, right? Hasn't it?
Yeah.
Single dart.
The balloon has crossed.
Balloon is crossed, yeah.
Yeah, I'm just going to pull back this.
Single
Just wait a second, I have to do the radiation.
Yes.
Yeah, so we can start from there.
Okay.
Go up to 8, 6, 8. अच्छा इसके बाद फिर ना जो 2.5 वो दे दें.
Yes.
6, 8,
6, 8,
10,
10,
12,
12,
14.
40.
Down. I can't see the dot. Yeah, actually. The heart and getting it back.
Then go up over there also.
Okay. Salman, we've got 5 more minutes before the next session, so if we can give that first round of inflation, give a little antigrade and see if we can see the distal flow, and then we know we're done. So what are you going to do afterwards? Are you going to do after an IVUS, would you just post-dilate and do a drug-eluting balloon or put another stent in there?
So what's the question?
So once you, inshallah, get this thing open, would you just use the drug-eluting balloon in the stent or put a stent right across?
That's there. I think we'll do IVUS if it's properly sized, and the problem is all biologic failure of the stent and it's properly sized, then I think we'll do a DEB. But if there's geographic miss up top, or maybe the stent is undersized, then we might consider DES. I was hoping to have an IVUS ready for you guys. I think that's not the balloon, that's something else. Balloon thingy hai. So we weren't there, so.
Yes.
Yeah, balloon nabara. So, okay, why don't you go up there, please? So that wasn't the balloon, guys. That was just a wire transition point.
Okay. 10, 12.
10, 12?
12.
Oh, go step. Because I have to anchor this in.
Okay. 12.
You know, your guide thing, I think there's something wrong with the guide because I can't see how the guide extender is not going there. There's something not right with the guide. Okay, come down, please. Okay, go up again, please. Yeah. You know, the low profile of the balloon, I think we lost it by prematurely inflating it in the guide. There's a kink in the guide there, guys. You see how the guide extender just gets stopped there? So let's do this. Give me the new 2.5 balloon, please.
New 2.
Yeah, down, come down.
Okay.
We like to keep the balloon at the tip of the guide.
Yeah.
Flip it off.
2.5, yeah. नहीं NC नहीं compliant है कि compliant कौन सा है? Do you have 2.0? अच्छा, do you have a 1.25 या कोई और so I can go deeper with this?
115.
हाँ ठीक है, that's fine. So if you have another case, maybe we can try and finish up here and then we can show you a result in a bit. I just have to get my equipment all lined up. So what I'll do is I will actually go and angioplasty with a new balloon. I think the new balloon has a different profile. I think we lost that advantage because we thought the balloon marker was actually the wire transition.
Salman, we're going to wait to see if your 1.25 crosses or not, and then we come back in the middle of the next session to see what you've done.
That's fine. Let's go. Yeah. नहीं और यहाँ पे screen भी छोटी है. I'm used to a bigger screen, so it's a bit of an adjustment, but that's okay. I feel bad about not seeing the balloon marker.
Yeah, the bigger screen really for the other case.
Ah.
Yeah, this is a really challenging case, and I think there's been a lot of progress made here. There's some limited equipment here. Do you have, in terms of catheters, what I've tried that really helps is something like a turnpike spiral. I mean, these are catheters that have grooves in them, and then you can use them as sort of a screw. Again, I recognize the challenges that you have there. I guess that would be a suggestion. And the other thing is that I think that if there were large branches here, maybe you could utilize one of those branches, an RV branch or even conus, to try to anchor, to use another wire in a smaller balloon to try to do some anchoring there. I don't know if that's possible.
I think fantastic idea. So I think this is one of the, again, areas where using a spiral is absolutely beneficial. I don't know if you have one, because I think that extra nylon braid can wrap around, can dig into it. We did see an RV branch. I may consider that next. Let me see if I can go with this balloon a little farther.
Salman, can I suggest another thing? This is Javed again from UK. Is that why don't you inflate a small balloon halfway into the guide catheter extension as well as into the guide catheter and then bat it? That may go actually.
Okay.
And that will provide you extra support once you have your guide catheter extension inside the stent.
Agreed. I think that's a great idea. I was thinking of angioplasting the guide. So we've done guide angioplasty for kinks. So you're absolutely right. So let's take
That's a great idea, Javed.
Can we have a
we don't realize sometimes it's a kink. So, Salman, we've short of time. We're going to the next session, and we'll drop in and see what you guys are doing in a little while. Right.
Absolutely.
Good luck to you.
Thank you so much.
Right. While you angioplasty the guider, we'll switch to the next session. Yeah.
You saw a lot of new things today.
And thank you very much for the Wadi panelists. They were wonderful. Thank you for being there. And
one comment I want to say: if you are feeling difficulty in crossing.
Thank you, Dr. Swail and Dr. Nadir, for a wonderful session. Is Dr. Tahir Sagir here?
Will go for the rotation.
I guess
I'm here, Bashir.
He's not here.